you have lost. The remaining whitish part, that much vision is still left, and with medications, it can definitely taken care of. So treatment, why again? To prevent the further visual loss. Now the treatment has to be decided between the doctor and you because there are different modalities of the treatment. Treatment is in the form of drops, treatment are in the form of lasers, treatment is in the form of surgeries. Now all these drops are quite expensive drops for glaucoma. Every month you need to spend around $1,000. So these drops has its own side effects. So, and these drops you have to continue throughout your life. So you need to decide that will I be able to continue the drops, and these drops has to be meticulously instilled and at a specific time. Half an hour plus minus is well and good, but you need to instill at a definite, you can't make it like today at 7 p.m., tomorrow at 12 p.m. That won't help. So those things you need to discuss with your clinician, as well as what are the side effects of the drop and will you be able to bear it or not, those side effects. So as we said, drops, which is the most common. Iridotomy, that with lasers, what we do, we make a hole inside the eye. Inside the eye, you can see here a hole. The purpose of this hole is that the water that is not going out, through that hole, it goes out from posterior to anterior and then seeps out through this hole. And if this also doesn't work, then the last resort is the surgery. And that surgery called as trabeculectomy. We make an artificial tunnel in the eye through which the water seeps out and passes through another channel called that uveoscleral outflow. Well, now coming to my last topic is the diabetes again. My talk will be restricted to the eye part only. So as we said, and everybody now knows that one should not ignore once it is diabetes, because diabetes is a disease that affects from head to toe. And India stands the topmost country, and it can be called as the diabetic capital of the world. Well, we say that Mera Bharat Mahan, but every fifth Indian is a diabetic, as per the statistic goes, and 25 to 36% out of which develop retinopathy. So other than this diabetes, once it takes place, other than retinopathy, what other things it can affect in the eye? It can affect the nerves, like the third nerve, fourth nerve, seventh nerve. These are the oculomotor nerve, trochlear nerve, the facial nerve, the abducens nerve. Now these nerves, these nerves helps us in looking at different angles. For example, I'm turning right or turning left. Why we are able to turn this? Because the nerve gives the stimulation to the muscles and then it forms. Now, because of diabetes, these nerves get hampered and you can develop palsy. So there are sixth nerve palsy, fourth nerve palsy, and this causes diplopia. You will see double images, and these things doesn't have permanent repair. We don't have any medicines or any surgeries also that we give you, or we just take you for the surgery and the problem solves. You need to control your diabetes. We need to wait for minimum 6 to 8 months, and still if it doesn't recover, then we have to prescribe you through prisms, or surgery is the last resort, but with no assurance. Now again, a diabetic patient, specifically if the diabetes is not controlled and if it's fluctuating. Now patient generally complains of, for example, if somebody comes to me, I prescribe him or her a glass par, suddenly he comes to me after 3 months and again says that the number that you had given me, the number is changed. So why? Diabetic patients doesn't have a stable glass number if it is not under control or if it is fluctuating. The numbers keep fluctuating. So hence, again, the only resort is you need to control diabetes. Why this number gets fluctuated? Because the lens that is inside the eye, because of some pathway called the sorbitol pathway, the lens swells up. When the diabetes decreases or the sugar levels comes back to normal, again the lens shrinks down, and again you can see nicely. Now diabetes induces cataracts also. Now as we say, different types of cataracts, again this is another type of cataract called as the snowflake cataract. This type of cataracts are more commonly seen in diabetes. Again, diabetic cataracts are difficult to operate. Why it is difficult to operate? Because after instilling the drops also, the pupils doesn't dilate. So we don't have a clear visual field while operating. So hence, diabetic cataracts doesn't dilate pupils. Again, these cataracts are elastic cataracts. When you try to pull them out, they doesn't come out. They stick in. They're very sticky. Now coming to the retina. Retina is nothing but a curtain behind the eye. Through this curtain, we are able to see. Now there are 4 causes mainly why we see. One is because of the cornea, because of the lens, because of the optic nerve, and because of this retina. Now cornea and lens, they are replaceable. Once they get damaged, we can definitely replace back. Cataract, we can do the surgery and put an artificial lens. Cornea, we are now keep on saying that please donate your eyes, please donate. For the reason is that for corneal transplant, it's not like the entire eye gets transplanted. It's only the cornea that we are able to transplant. But retina and optic nerve, we don't have any remedy. Means once it is damaged, it is damaged. So we need to prevent them. And among the retina, the central part is called as the macula. This macula through which we see maximum. There are innumerable number of rod cells in this area of macula, and through which we are able to perceive a good vision. So if the retina is also fine and the macula is damaged, then also we don't have a clear central vision. The peripheral vision will, but centrally we will see black spots. Now, diabetes can lead to different sort of retinopathy. The term retinopathy is a generalized term that we say, okay, you have got diabetes, retina is hampered, hence you have a diabetic retinopathy. But out of the retinopathy, there are different grades of retinopathy. Like in this mild diabetic retinopathy, you can see here small, though because of the light we can't appreciate much, but you can see small bleeding spots. These are called microaneurysms. Microaneurysms takes place. Why it takes place? Because the endothelial lining, these are microvascular damage takes place. The endothelium gets hampered and there is formation of small pericytes. This is a scientific terminology, pericytes, that leads to this microaneurysms. Now again, if it is more controlled and still you have not visited the doctor and somehow you have neglected, that can lead to moderate diabetic retina. Now you can see this clear blood vessels. These are like cotton wool spots, means retina has 10 layers. The nerve fiber layer gets damaged and that leads to this kind of picture. And here you can see over the macula also there are bleeding spots. That leads to diabetic macular edema. We'll come in the picture later. This is again the severe form of diabetic retinopathy, and this is what diabetic maculopathy, where you get hard exudates. And these things can't be treated. Very honest and very frank, once you have these things, you can't, only thing what we can try is that it doesn't progress to the next level, which is called proliferative diabetic retinopathy. In proliferative diabetic retinopathy, there are NVEs, neovascular vessels elsewhere. What are these NVEs takes place because of the diabetes, because of the damage to the blood vessels, there is ischemia takes place. And because of this ischemia, just like the heart, myocardial infarction and all, infarction takes place inside the retina, and that leads to formation of new blood vessels. And if left untreated, this is the final fate, where you get tractional retinal detachment, where you get subhyaloid hemorrhages. These are hemorrhage that has taken place. So this is the last resort in which there is no treatment of this. This is the gone. So how do you look out for symptoms? As we said, that blurring of vision, black spots around, and you will may develop diplopia. You will see 2-3 things. You are seeing 2 faces, 3 faces. It is called diplopia. So treatment modalities for diabetic retinopathy. Initial stage, in the milder form, obviously we start giving you with oral medications. 1 tablet once a day. There are different companies, different brands, different tablets. In the second phase, where there is moderate diabetic retinopathy, we start doing lasers. Laser is a treatment where we burn the retina. After burning, the purpose of burning is that we damage that ischemic spot and we create a hypoxia. So hence the new vessels gets damaged. And there are different injections which are available these days, intravitreal injections. We inject it inside the eye so that blood vessels automatically get subsided. And if there is any edema means sujan वगैरह अगर आते हैं, edema, that edema also subsided. And last resort is the surgery. So post laser, this is the picture that you get. These are the laser spots. This is called in medical term PRP, pan-retinal photocoagulation. So these are the multiple laser spots we give. We don't give it over the macula because macula is the one area that we don't want to damage. The rest, all these laser spots we do so that new blood vessels doesn't form over there. So post laser, this is how it looks, pre-treatment and post-treatment. You can see this black scarring spots. The purpose of doing laser is that the eye should not get damaged further, but it is not, the purpose is not like that. Whatever you have lost the vision, you will gain it. That is not the purpose. So these are the different injections available in the market that we instill in the eye. And this is the surgery that we do. We do vitrectomy once the vitreous is removed. And this is how it looks before surgery and after surgery. Thank you.
Thank you, Dr. Chatterjee. Is there any questions you would like, sir, to answer?
Sir, I have seen the patients complaining in the middle age with some hypertension, diabetes and all. They have the dribbling of the tears
They
all
have
the time.
dribbling of tears. Okay, means continuous water comes out.
Yeah.
Okay.
What is the reason and what will be the treatment?
First of all, it depends what is the occupation of the patient, one. Second, if the patient is a diabetic, hypertensive or not. Third, whatever is the occupation, what is the ambience in which he or she is working. So lot of
She's
one of
working in the hospital. She was.
the main reason for this is that patient has got dry eyes, because of which the tear and hence there is lot of blinking sensation in the eyes, and that leads to artificial dribbling of the tears.
Reason of the dryness?
Is a female patient or a male patient?
Female patient.
What's the approx age?
66.
So 66, any patient who is a post-menopausal patient, the dryness also depends on estrogen hormone. When the estrogen progesterone hormone shifts after menopause, then this dryness is much more common in females.
So treatment,
We have
steroids throughout
no,
the
no,
life?
no, not at all steroids, ma'am.
It's
It's
applied.
artificial tear supplements has to be given, and that has to be given lifelong.
Okay. Second question, cataract operation is done on both eyes to a diabetic patient.
Cataract operation is?
Done on both eyes.
Yeah.
And the patient is a diabetic case.
Okay.
Will there be any problem later on?
Again, if the diabetes
It's
is
controlled, well controlled.
if the diabetes is well controlled, then as such no problem. The game of diabetes is that as long as you keep it under control, there is no problem. But again, which is very important, for how many years the patient is diabetic. If the patient is diabetic for 3, 4, 5 years, absolutely there is no problem. But if the patient is diabetic for around 20 years, 25 years, then obviously mild problems will definitely come across.
Of such, which?
Like I showed you, mild diabetic retinopathy and all, those problems will be there.
Okay, thank you.
Is there anyone?
Hello, Dr. Sushant.
ma'am.
A very nice talk from you. It was very informative. My question is, can we label a patient a glaucoma patient if, in case the IOP, the intraocular pressure is normal, but there is any change in the cup disc ratio?
Yeah.
Do we have such patients, and how should we go about such patients?
There is a term called normal tension glaucoma. It is called as NTG. In such kind of glaucoma patients, the pressures are always below 20, but they will be in the range of 16, 17, 18. Now, glaucoma is not only diagnosed if the eye pressure is raised. It's very important. You have to correlate with the eye pressure and how is the status of the optic nerve. If both the things match, then we do the perimetry. If it shows that